Our next speaker is also virtual. It's Dr. Cezmi Akdis, who's the director of the Swiss Institute of Allergy and Asthma Research, was a former editor of the Journal of Allergy and Clinical Immunology, and is currently editor-in-chief of Allergy. And he will be speaking about epithelial barrier theory and the global health crisis.
Hello, thank you very much, David. It's a great pleasure to talk in this meeting. My name is Cezmi Akdis. I'm going to talk about epithelial barrier theory and global health crisis. These are my conflict of interests. Major threats to humanity and nature of the world is being discussed with global climate change and also global warming. I'm going to talk about another important major health crisis. This is global environment change and related diseases. It's about exposure to toxic substances and development of 2 billion patients. We are bringing this concept in the name of, with the name of epithelial barrier theory. And it's about also climate change inside our body. It's about epithelial barrier damage, microbial dysbiosis, and immune system activation. This is our curve of allergy and asthma pandemic, but it's very similar in many autoimmune diseases. John Bostock described the first case of allergic rhinitis, and Charles Blakely had the first series with the name of hay fever, hay asthma in his book. It took him 3 years to collect 28 cases. And at that time, there was allergic rhinitis and allergic asthma reported as diseases, but the prevalence was relatively low. When we come to 1900s, there was about 1% of allergic individuals in the Swiss army. And in 1960, we also see around 1 to 2%. But after 1960, we see a very steep increase in the number of allergic patients, 4.4%, 8.4%, 26%, 43%. And this increase is very important, of course, for our specialty. And at the same time, chronic non-communicable diseases. In 1960, we had 20-30 million patients in the whole world. And currently, we are having around 2 billion patients, chronic non-infectious disease patients. There's 100 times increase in these numbers. So we are having a second, actually very steep increase. This is about food allergy, eosinophilic esophagitis, and drug hypersensitivity. And this second steep increase, you know from your own specialty that when we were assistants, food allergy was existing, but it was not a very severe health problem. Eosinophilic esophagitis was described in our institute in around 1996. As well, it took some time to collect these patients by Alex Straumann and Hans-Uwe Simon. But currently, the prevalence of eosinophilic esophagitis is also 0.5%, and drug hypersensitivity is also showing a very steep increase. What happened after 1960s is a very important question, and this is the reason for global health crisis. And that's what we think. And there's 350,000 new substances introduced to animal and human lives with almost no control on their health effects after 1960s, and many of them ended up as pollutants. And this is a very important change in our environment, and we are now working on these substances one by one and with the concepts of epithelial barriers, and we are looking at what happens to epithelial barriers when we are exposed to these toxic substances. So if we want to understand the functions of epithelial barriers, they are sealing the very apical side of the epithelial cells, and this is, let's say, lung mucosa or the gut mucosa. And closed epithelial barrier means that these are tight junctions. It is preventive and protective against the environment. And open tight junctions are important. If there is too much inflammation below the epithelium, then it's important to drain this inflammation. But at the same time, it allows allergen, pollutant, toxin accessibility. Our work on epithelial barriers has been a very important part of our research in the Institute. And we started in 1998 working on epithelial cell apoptosis. And we described the skin, lung, and sinus apoptosis as mechanism of eczema in the skin, in atopic dermatitis, and in the lung, epithelial shedding, and also in the sinus. In 2006, we described major functions of epithelial barrier as keep away factors, physical barrier, laminar reticular thickening, and IgA production, and wash away factors, mucus, ciliary movement, and opening of the barrier and drainage of the expulsion response, and suppression factors, immune regulatory cells, and cytokines. We have research on starting from 2009, working on mechanisms of epithelial barrier changes and how immune system and inflammation regulates tight junctions. T cells, type 2 innate lymphoid cells, and IL-13 play major roles in changes of epithelial barriers. And since 2015, we are continuously publishing on global exposome and how the global exposome changes epithelial barriers like detergents, surfactants, ozone, emulsifiers, and particulate matter disrupting the epithelial barriers. And we are working on organoids and organs on a chip. And also we developed a device called skin impedance meter. So the current situation is that the epithelial cells in many individuals in the respiratory area or in the gut are not strongly touching each other. There is space between epithelial cells, and this barrier is broken and leaky. And the microbiome passes through the epithelium and makes some microbial translocation. And there is so many factors we have identified in our research. And when the barriers are leaky, allergens, toxins, pollutants, microbiome, and opportunistic pathogens are passing through the epithelium and affecting the deeper tissues. And when we look at the factors, we have here identified laundry and dishwasher detergents, surfactants, sodium dodecyl sulfate, which is also sodium lauryl sulfate, and sodium dodecyl benzene sulfate, ozone, diesel exhaust, cigarette smoke, nanoparticles, enzymes and emulsifiers in processed food, shampoos and body cleaners, household cleaners, toothpaste, particulate matter, and microplastic. So I would like to talk about detergents and surfactants as the main factors. And here we have sodium lauryl sulfate as the main culprit. Sodium lauryl sulfate was added to powder detergents in the US exactly in 1960. And in the beginning, it was around 20%. Nowadays, it's around 10%. It's also in shampoos, household cleaners, between 5 to 10%. And after 2000, it was added also to toothpaste very commonly. And it's around 3% in toothpaste. And cosmetics and skin cleansers also contain sodium lauryl sulfate. And it can be extracted from house dust, pillows, bed sheets. So here are first results that we have been working on laundry detergents, and this is 1 to 50,000 dilution of a laundry detergent. And the normal rinse factor of a laundry at home at 40 degrees is around 2,500 times. So this is 20 times more diluted detergents, and we have here healthy, asthmatic, and COPD epithelial cells. And what we are seeing here is that lipid metabolism, oxidative stress, cell survival, and IL-13 are upregulated. Cell adhesion, extracellular matrix organization, and wound healing are downregulated. The interpretation of all these results is that there is a chronic wound in the asthmatic lung that tries to survive itself. So the main culprits were identified from detergents as sodium lauryl sulfate and sodium dodecyl benzene sulfonate. A very interesting paper was published by Hideaki Morita and his group. And here we see that sodium lauryl sulfate or detergents were added to the noses. They are administered to the noses of the mice and only for 4 days. And the doses are 0.1 and 1%. And these 4 drops of sodium lauryl sulfate in mouse lungs, it caused a very severe inflammation. We can see that there's increase in total leukocytes, a very significant increase in eosinophils, and also neutrophils. And we looked at the cytokines or factors, how this inflammation is increasing and how eosinophilia is increasing. And we can see that this is IL-5 reporter mouse, and type 2 innate lymphoid cells are responding with IL-5 production very significantly when they are exposed to detergents. Basophils and T cells have no effect. Another important factor is epithelitis. So when the mice are exposed to detergents, their lung epithelial cells start to make IL-33. Here we see around 30, 40 lung cells that make IL-33, and this is the control here. And we looked at this in the IL-33 knockout mouse. And if IL-33 is deleted, is deficient in the mouse, you can see that there is no eosinophilic inflammation in the same conditions. And this is a very important finding. So this study shows a very important finding that only 4 times exposure to relatively low dose of sodium lauryl for example, which is around 10% in the detergents and around 3% in the toothpaste, is causing some very strong eosinophilic and neutrophilic inflammation through type 2 innate lymphoid cells, IL-33 production by epithelium, and type 2 cytokines, IL-5 and IL-13. Another important study just recently published came from the Mayo Clinic, and this is about sodium lauryl sulfate and eosinophilic esophagitis. Here we see that sodium lauryl sulfate damages human esophageal epithelial barrier and stimulates IL-33 production. This is a very significant IL-33 production. We can see here the mouse esophagus, and this is the normal control mouse esophagus, and here is sodium lauryl sulfate, 0.5% administered esophagus, and you can see that there is a big degeneration and inflammation in the esophagus in very short time, and we can see here eosinophils stain very nicely. The summary of this study is that exposure to sodium lauryl sulfate decreases epithelial barrier integrity and induces epithelitis with increased IL-33 production and also eosinophilia, and there is inflammation, abscess formation, CD4 positive T cell infiltration as observed in human biopsies. So the third study which I would like to mention about this is laundry detergents and mouse skin, and here we have 10,000 times diluted commercial detergent and only 4 hours exposure in the skin is causing inflammation. We have recently developed a device that measures skin barrier integrity by skin impedance meter. And this is the device, and here is the data. When the mouse are exposed only for 4 hours to 100 times diluted detergents, we can see a very significant decrease in skin impedance, which lasts for 48 hours, and then there's recovery. The same is happening also in 10,000 times diluted detergent exposure. The decrease is a little bit less, but significant, and then this continues, and then there is also, again, recovery. So what this device is used a lot nowadays in our lab and also in several clinics, and it's diagnosis for various skin diseases, melanoma and skin cancers, treatment follow-up in atopic dermatitis, clinical trial monitoring in atopic dermatitis, and early prediction of treatment response in atopic dermatitis. What's very close to our hearts is early prediction of infantile eczema, atopic development in babies, that we are measuring babies at the time of 1 month and 4 months, and we're looking at the skin impedance and predicting the future development of infantile. So the level of evidence here for household laundry detergents and cleaners, particularly SLS and detergent enzymes, is for humans. There is very high numbers of occupational exposure, cases of asthma, rhinitis, and dermatitis. Mouse in vivo, as I have shown, lung, skin, and esophagus studies have been published. And in vitro, we are doing mechanistic studies in organoids, organochips, and induced pluripotent stem cells that show the toxicity of these compounds. We move on the gastrointestinal system, and now we are looking at very shiny glasses, which is the case in the last 20 years in our life, which are introduced to our lives around 1960s with household dishwashers. But after 2000, we are using professional dishwashers. A professional dishwasher washes the cutlery and the glasses and plates within 1 or 2 minutes. And in the beginning, it increases the temperature to 82 degrees for atmospheric pressure, and there is no rinsing. The rinse aid is added in the last 20 seconds. It kills the foam, and it's dried on the wash material. And particularly, we identified that rinse aid is toxic, and the toxic material is alcohol ethoxylate. As you know, alcohol is toxic to cells, but alcohol ethoxylates, these are synthetic alcohols, are very toxic in the dilution of 1 to 20,000. And alcohol ethoxylates is the shining compound remaining on the glasses, plates, and cutlery, and it could be extractive effects can be shown. Here we see the detergent is not toxic, the cells are alive, but this is here down to 20,000 times dilution. And we can see that there is a very significant cell death observed in 40,000 and unexposed. We don't see any cell death. And this toxicity can be extracted from glasses, from the dishes. Here we can see professional dishwasher shows this toxicity in undiluted when we put medium in the glasses, just stir it a few times and collect it after filtering. You can see the toxicity 1 to 2 dilution, 1 to 5 dilution. And this is transepithelial resistance. And we can see here again, undiluted 1 to 2 diluted dilution, 1 to 5 dilution, the very visible toxicity of the substances that we have extracted. So we come here to another important change in our lifestyle. This is packaged food and emulsifiers, preservatives, and surfactants used in packaged food. The commercial aim is to extend the shelf life. The shelf life of packaged food was around 7 days about 20 years ago, which is now about 6 months. And the commercial aim has been successfully achieved. Shelf life of packaged food has increased to several months, and the mechanism is to kill fungal growth and bacterial growth and provide a thickening effect. Is it possible to do this without harming human cells? No, it's practically impossible. Here is two commonly used food emulsifiers. These are polysorbate P20 and P80. If you have done any STS gels, Western blots, you are using these. These are twins 20 and twin 80, and it's very toxic. The allowed doses in the US is around 1%, and here we can see that 1% is killing all the cells, and 0.1% is the limit, and 0.05% unexposed. They are not toxic to the cells. But these toxic doses are commonly used in pastry, in ice creams in the US, and here is a long list of emulsifiers in the US and Europe. And we are checking nowadays all of these emulsifiers, whether they are toxic to cells and whether they are toxic to induced pluripotent stem cell-made organoids, skin, gut, also respiratory tissue. And we are looking at now another page, a second page. Level of evidence for food emulsifiers is that for humans, we don't have epidemiological evidence, but we know very well that quite toxic doses are allowed currently. And in mouse in vivo, there's many studies on gut inflammation, epithelial barrier, microbiome studies, and they are convincing at a high level. And in vitro studies are continuing with organoids, organoid chips induced pluripotence. And the micro and nanoplastic is important to mention here shortly. And the plastic production is 8 billion tons per year, and around 1 billion ton per year arrives in our organs as microplastic. Microplastic can be detected in deeper tissues in humans now, also in babies, and it's ingested by cells, immune modulatory, epithelial barrier opening, and receptor binding. And plastic pollution has a major impact in our life, and it's a serious danger for all living organisms. So this research is going on. And for the evidence, micro and nanoplastic detection in body fluids and deep tissues is very well known nowadays. And there's high numbers of reliable studies for mouse in vivo effects of microplastic, nanoplastic, or angstrom size of plastic, and in vitro mechanistic studies have been. I would like to mention here shortly that there's comorbidities and multimorbidities that also increased in the meantime during the last 20 years. So we are selecting epithelial barrier-related diseases based on these 5 criteria. Increased prevalence after 1960s or 2000s that are not affected with the changing method of diagnosis. The second main criteria is epithelial barrier defect and epithelitis that we measure IL-25, IL-33, TSLP production, and microbial dysbiosis and loss of commensals and colonization of opportunistic pathogens is an important criteria, and multimorbidity. Different and practically irrelevant diseases that fulfill these criteria appear in multimorbidities. And a new term is coming here, circulating microinflammation. So we are looking at individuals and we are checking at factors that increase in their circulation in obesity, in diabetes, in autoimmune diseases, and other. So we have 3 groups of diseases. The first group is allergic diseases and certain autoimmune diseases where epithelial barrier defect and microbial dysbiosis is taking place in directly affected tissues. Here we have atopic dermatitis, asthma, chronic rhinosinusitis, allergic rhinitis, eosinophilic esophagitis, inflammatory bowel, and celiac. Second group is autoimmune and metabolic diseases linked to mainly gut barrier defect, but sometimes chronic sinusitis and also periodontitis. We have here the diabetes, obesity, fatty liver, autoimmune hepatitis, liver cirrhosis, rheumatoid arthritis, multiple sclerosis, systemic lupus, and ankylosing spondylitis. And now we have here a third group of diseases. The level of evidence here is not so strong because we don't have good animal models for these diseases. But here we have autism spectrum, Parkinson's disease, Alzheimer's disease, stress-related psychiatric disorders, chronic depression. And when we biopsy these patients, we see enteric inflammation, epithelial barrier defect, and microbial dysbiosis. These are all published, but the research go on in these groups. So to better understand this, we have published several review articles. You can look at these review articles. Now let's look at the mechanisms. One of the most important thing is the interaction of the microbiota and epithelial cells. This is an agreement between prokaryotic cells and eukaryotic cells for digestion, for providing nutrients, vitamins, metabolites, education of the immune system, cell differentiation, and tissue maturation. Unfortunately, this agreement is broken, and this is an agreement of several 100 million years, and it doesn't work since 1960s. Instead of having 4,000 species of bacteria in our gut, we are now having in the diabetic patients in obesity 800 species. Same for skin. Instead of having 800 species, there is now 300, 400 species in the skin. So we lost the biodiversity in our bacteria. So in the mechanisms, we are looking at three things: epithelial barrier damage, microbial dysbiosis, and immune system. So let's start with epithelitis. When we are exposed to epithelial barrier damaging substances, which I have listed in the beginning of the talk, then we see that the epithelial barrier opens and microbiome starts to migrate deeper in the tissues and translocates beneath the epithelium. And at the same time, the alarmins are produced, IL-1, IL-25, IL-33, and TSLP, and the immune system is invited to the area, and the activation of the immune system and also colonization of opportunistic pathogens is taking place. And we see the expulsion response. Type 2 immune response and expulsion response is taking place. And here we see that the immune system is activated and trying to throw away these bacteria and trying to get rid of these bacteria to avoid sepsis. And the players are IgE, eosinophilia, open barriers, cough, T helper 2 cells, ILC2, and our main cytokines, IL4, IL5, and IL13. At the same time, there is detectable autoimmunity and there is loss of biodiversity. What are the reasons of loss of biodiversity in microbiota? There are three main reasons. One of them is colonizing opportunistic pathogens change the biodiversity. Immune response to commensals is important, and this immune response, together with immune response to opportunistic pathogens, decreases the commensals. And there is direct toxicity of environmental substances to commensal bacteria. These three are quite important. With this slide, I would like to stop my talk. And we have genetic reasons and exposure to barrier damaging agents and opening of the epithelial barriers. Colonizing of opportunistic pathogens follows this. Then translocation of microbiota to subepithelial areas is taking place, and immune response to commensals and opportunistic pathogens. Then we have loss of commensals, microbial dysbiosis, and decreased biodiversity. And inflammation in the epithelium and chronicity takes place, and defective epithelial barrier healing capacity is happening. So in summary, we have direct toxicity to epithelium and microbiome, epithelitis and alarmin production, expulsion response, circulating microinflammation, and epigenetics and chronicity are taking place. I'd like to thank all our workers and invite you to our Congress, which will be on the 13th of March next year. Thank you very much for your attention.